This is Mazen Judi, Assistant Professor in the Medicine Department in the Baghdad Medical College. By the name of God, I would like to present the fifth lecture in the infectious module for the third stage. This is regarding the typhoid and paratyphoid fever, which is enteric fever and brucellosis. So the contents in this lecture to discuss these two problems. Let's start with the typhoid fever and paratyphoid fever, which is the enteric fever. These diseases are caused by infection with Salmonella species, Salmonella typhi and Salmonella paratyphi. A and B. Typhoid is spread by eating or drinking food and water that is contaminated with the feces of an infected person. After a few days of bacteremia, the bacilli localize mainly in the lymphoid tissues of the small intestine, and that will result in lesions in the Peyer's patches and follicles. These swell at first, then ulcerate and usually heal. After clinical recovery, about 5% of patients become chronic carriers, that is to say, continue to excrete the bacteria after 1 year. The bacilli may live in the gallbladder for months or years and pass intermittently in the stool and less commonly in the urine. Now, what are the clinical features of patients with enteric fever? The incubation period is typically 10 to 14 days, so it is about 2 weeks, but can be longer, and the onset may be insidious. The incubation period is the period between the infection and the clinical features. The temperature rises in a step ladder fashion for 4 to 5 days, with malaise, increasing headache, drowsiness, and aching in the limbs. Constipation may be caused by swelling of the lymphoid tissues around the ileocecal junction, although in children, diarrhea and vomiting may be the prominent features early in the illness. What about the pulse? The pulse is often slower than would be expected from the height of the temperature, that's to say, relative bradycardia. So the temperature is elevated, but the pulse is decreased, and that is what is called relative bradycardia. At the end of the first week, a rash may appear on the upper abdomen and on the back as sparse, slightly raised, rose red spots which fade on pressure. So the question, is there dermatological features with the typhoid? Yes, as rash that appear in the end of the first week that fade on pressure. It is usually visible only on white skin. And also, in addition to these dermatological features, the patient may develop cough and epistaxis sometimes. Around 7th to 10th day, the spleen becomes palpable. The patient may develop splenomegaly. Constipation is then succeeded by diarrhea and abdominal distension with tenderness. So also the bowel habit will be changed. Bronchitis and delirium also may develop. In untreated patient, at the end of second week, the patient may be profoundly ill. Now, what are the clinical features according to the weeks? We can divide them into 3 groups. And the first week, as I said, with fever, constitutional features of headache, myalgia, constipation, also diarrhea and vomiting may develop, especially in children. While in the end of the first week, there are rose spots on the trunk, and also splenomegaly, cough, abdominal distension, and diarrhea. And in the end of the second week, the patient will develop delirium, complication, even coma and death if he is not treated properly. What about the term paratyphoid fever? Paratyphoid fever, the cause in this condition tends to be shorter and milder than that of the typhoid fever, and the onset is often more abrupt, with acute enteritis. The rash may be more abundant, and the intestinal complications are less frequent. Okay? Now we see patient with the suspicion of typhoid fever. What are the investigations done for him? In the first week, diagnosis may be difficult. In this invasive stage with bacteremia, the symptoms are those of generalized infection without localizing features. Actually, the test in the first few days and the first week may be negative. And then a white blood count may be helpful, but the CBC shows leukopenia, fever, relative urticaria, and leukopenia. All these features make our mind think in the possibility of typhoid fever. Blood culture is the most important diagnostic method, of course. If we do culture for the microorganism and then we isolate the microorganism, so it is the most important diagnostic method is the blood culture. The feces contain the organism more frequently in the second and third week. Also, feces examination for the microorganism. Widal test, this is important serological test, demonstration of antibodies against Salmonella typhi O osmotic and H. flagellar Salmonella typhi. The Widal test is negative in the first week. Okay, so this test done after the first week. Now, if we diagnose the patient with typhoid fever by clinical examination and also by the investigation, what are the approach? The approach is proper treatment. But if the patient is neglected without treatment, then he will develop complications. What are the complications for this disease? First of all is the hemorrhage from a perforation or the ulcerated bile patches may occur at the end of the second week or during the third week of the illness. A drop in the temperature due to normal or subnormal levels may be falsely reassuring in patients with intestinal hemorrhage. Additional complications may involve almost any viscous or system because of the septicemia present during the first week. Bone joint infection is common in children with sickle cell disease. So, if the patient neglected may develop complications at the site of the infection, which may be by hemorrhage, ulceration of the bile patches, or may develop additional complication of other systems because of the septicemia. Bone and joint infection also may be the complication of typhoid fever and sickle cell disease, especially in, of course, children. Now, what is the proper treatment for patients with typhoid fever? The proper treatment, a drug of choice, is the use of fluoroquinolone, of course, which is the fluoxetine. When there is resistance to this drug, then the third generation cephalosporin, which is the ceftriaxone, or cefotaxime, is used as the first choice. And also oral antibiotic, yes, oral antibiotics are available, which include the cefixime, is alternative to the cefotaxime and others. Ampicillin, chloramphenicol, trimethoprim, sulfamethoxazole, ciprofloxacin are commonly used to treat typhoid fever in microbiology. The typhoid fever, when properly treated, is not fatal in most cases and reduces the case fatality to about only 1%. When untreated typhoid fever persists for 3 weeks to a month, death occurs and increase persists for 3 weeks or a month. Of course, the mortality percentage will increase. Death occur 10 to 30% in this situation. In some communities, however, case fatality rates may reach up to high 47%. So the ciprofloxacin resistance is an increasing problem, especially in the India and also Southeast Asia. Many centers are shifting from using ciprofloxacin as the first choice. For these people, recommendation is the use of the third generation cephalosporin like ceftriaxone. Azithromycin has been suggested to be better at treating typhoid in the resistant population than both fluoroquinolone drugs and ceftriaxones. Azithromycin significantly reduces the relapse rate as compared with ceftriaxone. Now, what's about the chronic carriers? Chronic carriers were formerly treated for 4 weeks with ciprofloxacin, but may require an alternative agent and duration, and this alternative use of a drug, of course, depending on the microbiology testing. What is the role of surgery in the management of typhoid fever? Is usually indicated in cases of intestinal perforation as an emergency surgery. If antibiotic treatment fails to eradicate the hepatobiliary carriage, now the gallbladder should be resected. So the second role is cholecystectomy in the situation of failure of eradication of hepatobiliary carriage for this infection. But the cholecystectomy is not always successful. Why? Because of the persistence of the hepatic infection. Now we discuss the other problem, which is the brucellosis. It is highly contagious zoonosis caused by ingestion of unpasteurized milk or undercooked meat from infected animals or close contact with their secretions. So this is the method of transmission of the infection. Brucella species are small, gram-negative, non-motile, non-spore-forming, rod-shaped Coccobacilli bacteria. These bacteria localize in the reproductive organ of the host animal, causing abortion and sterility. So it is one of the causes of sterility in the animals. They are shed in large numbers in the animal urine, milk, placental fluid, or other fluid. So it is a zoonotic disease affecting the animals and then transmitted to human. There are many species for the brucella, but the most important that may cause brucellosis to human being is the Brucella melitensis from sheep, highest pathogenicity. This is the character for this species. The other one is the Brucella suis, which is from pigs, also characterized by high pathogenicity. The other species is Brucella abortus, which is from cattle, with moderate pathogenicity. And the final fourth important one is the Brucella canis, which is from dogs and characterized also by moderate pathogenicity. Now, brucellosis in human is usually associated with the consumption of unpasteurized milk, as I mentioned, and also soft cheeses made from the milk of infected animals, primarily the goats infected with Brucella melitensis. So the dairy products is the source for this type of infection. Also, occupational exposure of laboratory workers and also veterinaries and the slaughterhouse workers. These occupation, of course, with animals are more dangerous for brucellosis than others. Brucella can gain entry into the human body through breaks in the skin, mucous membranes, conjunctiva, respiratory, and gastrointestinal tracts. So not only the consumption of dairy products, but also from abrasions sometimes of the skin, from conjunctiva, and even respiratory tract. The type of immunity is cell-mediated immunity is the principal mechanism of recovery. The host response to infection with the Brucella abortus is characterized by development of tissue granuloma, indistinguishable from those of sarcoidosis. What is the granuloma? It's the localized collection of epithelial cells, and this collection a specific pathological character. It also occurs in other diseases like sarcoidosis, and here the granuloma in the brucella similar to those of sarcoidosis. In contrast, infection with the more virulent species, which is the Brucella melitensis and Brucella suis, more commonly result in what? Result in the visceral microabscesses. So there will be abscess formation in a situation of more virulent species. Although Brucella infection is primarily controlled through cell-mediated immunity rather than antibody activity, some immunity to reinfection is provided by serum immunoglobulin. So the major immunity type is cell-mediated immunity, but also humoral immunity, which is characterized by antibodies, immunoglobulin, sometimes is immunity to reinfection. Initially, immunoglobulin M levels rise, followed of course by immunoglobulin G titer. Immunoglobulin M may remain in the serum in low levels for several months, whereas immunoglobulin G eventually declines. Persistently elevated immunoglobulin G titer or second rise in the immunoglobulin G usually indicates a chronic or relapsed infection. What about immunoglobulin A? Immunoglobulin A antibodies are elaborated late and also may persist for long intervals. So immunoglobulin M, immunoglobulin G, and immunoglobulin A are examples of immunity against this type of infection. What are the clinical features of patients with Malta fever or with brucellosis? Brucella species are intracellular organisms that survive for long periods within the reticuloendothelial system. And this is a very important point because it explains many of the clinical features, including the chronicity of the disease, and also tendency to relapse even after antimicrobial therapy. Why this occurs? Because of the presence of this microorganism intracellularly within the reticuloendothelial system. Acute illness is characterized by high swinging temperature, so fever, with rigor, lethargy, headache, joint pain and muscle pain, and also scrotal pain. All these are the clinical features for patients with brucellosis. Occasionally, delirium occurs, abdominal pain, also constipation can occur. Now, what are the physical signs? Physical signs are non-specific. For example, lymphadenopathy, enlargement of lymph nodes, enlargement of the spleen, splenomegaly, may lead also this to hypersplenism and thrombocytopenia. This figure showing the localized infection which occurs in about 30% of patients and is more likely if diagnosis and treatment are delayed. So it may be chronic disease and can give different clinical features like can affect the central nervous system, giving rise to meningitis, intracranial or subarachnoid hemorrhage, stroke. Also may affect the eye, giving rise to uveitis, retinal thrombophlebitis. Can affect also the cranial nerves in the face. Can lead to lymphadenopathy as hilar lymphadenopathy in the chest. May cause pneumonia or abscesses in the lung. It also may cause myelopathy and radiculopathy. may cause also myocarditis, endocarditis in the heart, may affect the hepatobiliary system by splenic abscesses and calcification, hepatitis also. It may cause the spinal spondylitis, sacroiliitis, psoas abscesses, may affect also the testes that give rise to epididymoarthritis. Sometimes it's misdiagnosed as mumps and even other diseases. Pancytopenia can be a character for chronic carriers of patients with brucellosis, suppurative arthritis, bursitis, synovitis, osteomyelitis. All these could be a localized clinical features for localized infection by Brucella microorganism. So what is the proper way for diagnosis of Malta fever? The definitive diagnosis depends on what? Of course, definitive diagnosis depends on isolation of the organism. A blood culture are positive in 75 to 80% of infection caused by Brucella melitensis and 50% of those caused by Brucella abortus. The bone marrow culture should not be used routinely, but may increase the diagnostic yield, particularly if antibiotics have been given before the specimen are taken. That's to say, the isolation of the microorganism could be by blood culture, could be by bone marrow, also could be by CSF culture. And the CSF culture in neurobrucellosis is positive in about 30%. Now, serology may also aid in diagnosis in endemic areas. Single high antibody titer of more than 1/320 or fourfold rise in the titer is needed to support the diagnosis of acute infection. The test usually takes several weeks to become positive, but should eventually detect 95% of acute infection. So the test for the diagnosis, either isolation of the microorganism or by serology test. Now, what are the serological tests? Identification of specific antibodies against the bacterial lipopolysaccharide and other antigens can be detected by different types of serological tests, including the standard agglutination test, Rose-Bengal 2-mercaptoethanol test, indirect enzyme-linked immunoabsorbent assay, which is the ELISA. False negative standard agglutination test may be caused by presence of blocking antibodies, and that is what is called the boson phenomenon in the alpha-2 globulin immunoglobulin A and in the alpha globulin immunoglobulin G fractions. Okay, so the serology test can detect the disease, but can give also to false negative, especially in condition of standard agglutination tests. ELISA typically uses cytoplasmic proteins as antigens. It measures immunoglobulin M, immunoglobulin G, and immunoglobulin A with better sensitivity and specificity than standard agglutination tests in most recent comparative studies. PCR, that is polymerase chain reaction, is fast and should be specific and superior specificity and sensitivity in detecting both primary infection and relapse after treatment. So the other way of diagnosis by use this molecular test, which is the polymerase chain reaction test, especially in situations of BUO, which is pyrexia of unknown primary origin, and the etiology is the brucellosis. Now, what about the possible sequelae of the Brucella infection and Malta fever? Possible sequelae include different system involvement, for example, gallimimus, hepatitis, arthritis, spondylitis, pancytopenia, when the patient presents with anemia, leukopenia, thrombocytopenia. Also, the patient may develop meningitis, uveitis, endocarditis Brucellosis and miscarriage, as mentioned before. Now, the patient has a history with suspicion of the Malta fever and clinical examination also, then diagnosed by isolation of the microorganism or by serological test. What is the best treatment? The gold standard treatment for this infection by daily intramuscular injection of streptomycin as 1 gram for 14 days and oral doxycycline as 100 milligram twice daily for 45 days that are used concurrently. Gentamicin, the alternative treatment for this method of treatment, is the use of the gentamicin as 5 milligram per kg by intramuscular injection once daily for 7 days is an acceptable substitute when streptomycin is not available or contraindicated. So the combination of aminoglycoside, streptomycin with the doxycycline, or if it is not available, we use the combination of gentamicin with the doxycycline. Doxycycline plus rifampicin as oral therapy only when they are used twice daily for at least 6 weeks. This regimen has been advantage of oral administration. Now, when we have to use 3 drugs orally, a triple therapy of doxycycline, rifampicin, and cotrimoxazole has been used successfully to treat Brucellosis. Doxycycline is able to cross the blood-brain barrier, but requires the addition of 2 other drugs to prevent the relapse. Ciprofloxacin and cotrimoxazole therapy is associated with an unacceptable high rate of relapse. So the best to use the doxycycline with aminoglycoside. Brucella endocarditis, in this situation, surgery is required for an optimal outcome. Cotrimoxazole and rifampicin are both safe drugs to use in treatment of a pregnant female with brucellosis. In situation of pregnancy, we can choose the specific antibiotic, which are the rifampicin or cotrimoxazole. Even with optimal anti-brucella therapy, of course, relapse still occur in up to 10% of patients with Malta fever. And currently there is no effective vaccine is available for humans. So in brucellosis there is no effective vaccine, but of course for typhoid, which is the previous disease discussed in this lecture, vaccine is present. So in this lecture we discussed these 2 problems, infectious problem, which are the typhoid fever and Malta fever, in details regarding the etiology, clinical features, and diagnostic treatment. Thank you very much, and I hope success for all our dear students. Okay.